Our next speaker is Ron T. Genselwoord from the Netherlands, and he's going to talk about current and emerging treatments for ADPKD.
Yes, thank you, Mr. Chairman, and would also like to thank the organizing committee to invite me to give here a presentation on current and emerging treatments of polycystic kidney disease. And these are my disclosures, and I'm proud to have been a member of the steering committee of the various trials that have been performed in this field. And when I'm invited to speak about the treatment of polycystic kidney disease, I think we have to first discuss what the general measures for chronic kidney disease, whether they are beneficial also in polycystic kidney disease. And as you know, there are three general measures to treat chronic kidney disease. That's a protein-restricted diet, blood pressure control, and inhibiting the renin-angiotensin-aldosterone system. And with respect to the first option, I think it was already in 1995 when Saulo Clar, in a subgroup analysis of the MDRD trial, showed that protein restriction had no value to postpone the need for renal replacement therapy, and then later a meta-analysis that was confirmed. So this is no option. And with respect to blood pressure control, I think we have to be honest that even for blood pressure control, there are no firm data in polycystic kidney disease what the target level of blood pressure should be. And the same holds true for inhibiting the renin-angiotensin-aldosterone system. There have been no trials that showed that inhibitors of the renin-angiotensin system do better than blood pressure control alone. And of course, we know from pathophysiology that this system is activated in polycystic kidney disease, but whether these agents that inhibit the disease really have more benefit than blood pressure lowering alone is yet unknown. What do we know? What we do know is information that we got from the HALT studies, and this slide shows you the HALT-B study that was published in 2014. And in the HALT-B study, patients with later stage polycystic kidney disease, defined as a GFR between 25 and 60, were randomized to either an ACE inhibitor or combined an ACE inhibitor and an angiotensin II receptor blocker, so combined RAS inhibition. What the authors showed is that after 8 years of treatment, there was no difference in the incidence of the composite outcome, and the composite outcome was defined as the incidence of death, end-stage renal disease, or 50% reduction in estimated GFR. And whatever subgroup they investigated, the pattern was the same, no benefit of combined RAS inhibition. The HALT investigators also studied what strict blood pressure control might do. And strict blood pressure control was, in this trial, a blood pressure systolic between 95 and 110. And there are people in my clinic that have a diastolic blood pressure that is even higher than this systolic blood pressure target. But it was dus a low blood pressure goal, systolic 120 to 130, or randomized to very low blood pressure, 95, 110 systolic. And after 5 years of follow-up, there was less increase in total kidney volume with the very low blood pressure. But when they looked at renal function, and that's shown here on the right, you can see that, again, after 8 years of follow-up, there was no difference between the two groups. And a subgroup analysis that has been published quite recently suggested that perhaps patients with very large kidneys may have some benefit with the very low blood pressure, but this is an underpowered subgroup analysis. So when these general measures to postpone the need for renal replacement therapy in polycystic kidney disease have not been studied well, and we don't have much information, we have to look for disease-specific treatments. And then we have to know the pathophysiology of the disease. And this cartoon shows you an ADPKD renal collecting duct cell. Unfortunately, during the last 2 decades, we learned a lot about the pathophysiology of the disease. And we know now that due to mutations in either the PKD1 or the PKD2 gene, that encode for polycystin 1 or polycystin 2. This complex of these two proteins is dysfunctional, and that because of this dysfunctionality, all kinds of abnormal processes are going on in these cells. And these abnormal processes lead to fluid transport, cell proliferation, cell growth, so to cyst formation and cyst growth. And when you know these intracellular processes, you can also predict which treatments might be beneficial. And it was predicted for mTOR inhibitors, for Vasopressin V2 Receptor Antagonist, and for Somatostatin analogues. And you know the story about the mTOR inhibitors that was published a couple of years ago in the New England, that these drugs were not effective in slowing down the rate of renal function decline. So hope is there only for the V2 receptor antagonist and the somatostatin analogues. And for the somatostatin analogues, there was hope based especially on a small-scale Italian study that suggested in a secondary outcome that there might be benefit of somatostatin analogues. And for that reason, we designed in the Netherlands the DPAC-1 trial. And the DPAC-1 trial is published today in JAMA. And we randomized 305 patients with polycystic kidney disease and later stage disease, and GFR between 30 and 60, to either lanreotide, given on top of standard care, or to standard care only. And after 2.5 years of follow-up, there was no difference whatsoever between the group treated with the somatostatin analog and the group that received only standard of care. So somatostatin analogues, in my opinion, are not the way forward. And the way forward, of course, this is a graph you all know. That's the results of the TEMPO 3/4 study, published in the New England with tolvaptan, in a huge number of patients with polycystic kidney disease, early stage disease, defined as an estimated creatinine clearance more than 60 ml per minute at entry, and enriched for rapid disease progression, so patients with a large total kidney volume. And what they showed is a 50% decrease approximately in the rate of growth of the polycystic kidneys, but more importantly, also a 26% reduction in the rate of GFR loss. When you look then at the various CKD stages to see whether the effect is uniform, here on the right you see the rate of eGFR change, in blue tolvaptan and in red placebo. You may get the impression that in the earlier stages of the disease, tolvaptan may have less efficacy. And I don't think that is true, and York just explained to you that in early stage disease, GFR can remain stable for quite a prolonged time before going down. And when there is no progression of the disease in CKD stage 1, you can also not show benefit of a treatment. So in these patients with CKD stage 1, we have to look at other disease parameters, looking at the rate of total kidney volume growth. And when you look then at the efficacy of tolvaptan, you see that in CKD stage 1 and CKD stage 3, it is exactly the same. So efficacy across all CKD stages. What about long-term follow-up? That was studied in the TEMPO 4/4 study. Here on the left part of this graph, you see a replication of the results of the TEMPO 3/4 study. Here in red triangles, the subjects that were treated with placebo, and in blue, the subjects that were treated with tolvaptan. And you see an immediate drop in GFR, a reversible hemodynamic effect, and then less decrease in GFR than on placebo. And when you stop treatment, the subjects that previously received tolvaptan are better off than the patients that previously received placebo. And that's a difference of 3 to 4 ml per minute. And that is, with a rate of GFR decline, a 1-year postponement of the need of renal replacement therapy. And thereafter, all these patients were instituted on tolvaptan. So the patients that previously received tolvaptan are reinstituted. And here in the blue triangles, these were the patients that previously received placebo. They are now instituted on tolvaptan, and you see that the effect that was obtained in the first part of the study, in the TEMPO 3-4 study, is well maintained during 2 years of follow-up with all patients on treatment. So a well-maintained, a sustained treatment effect. This was all early-stage disease. The FDA wanted more information, and they asked for another study, and that's why we did the REPRISE study. And in that study, we included patients with later-stage disease, and funny entry criteria, because subjects had to be 18 to 55 years and had a GFR between 25 and 65, or patients could be between 56 and 65 years and had to have a lower GFR. And on average, in this trial, we saw a 35% less decrease in GFR during the 1-year follow-up in this trial. And when we looked at subgroups, it is again quite uniform across all subgroups, but there is one clear exception, and these are these elderly patients that were added as entry criteria. An elderly patient did not have a benefit, and I think that also in clinical practice we should not treat elderly patients with PKD that still have a maintained kidney function, whatever their Mayo class is. What may this imply? This is an extrapolation of the results of the TEMPO study, and the TEMPO study, the average estimated GFR was 82, and this would be control treatment. This would be tolvaptan treatment. When patients could adhere to tolvaptan treatment for 18 years, we could postpone the need for start of renal replacement therapy with approximately 5 years. And how do these agents compare with other treatments that we give in our nephrology practices? And therefore I made this table, and I'm now comparing it with ACE inhibitors given for diabetic nephropathy. That is the study by Ed Lewis with captopril, but also looking at the MDRD study, the low blood pressure goal, here, for instance, the angiotensin II receptor blockers for diabetic nephropathy, the trials by, again, Ed Lewis and Barry Brenner. When you look at the efficacy of the TEMPO study and the REPRISE study, you see that the efficacy of these drugs compare fairly well with the other treatments that we give in our nephrology practice, the low blood pressure goals and ACE inhibition and angiotensin II receptor blockers. And when you look at the withdrawal rate in these trials, also the withdrawal rate with tolvaptan is almost similar as the withdrawal rates that you see with ACE inhibitors or angiotensin II receptor blockers. And this led the European Medicines Agency in 2015 to allow marketing authorization for tolvaptan, and they revised their opinion in 2018. And the indication in Europe is now to slow the progression of cyst development and renal insufficiency in polycystic kidney disease in adults with CKD stages 1 to 4 and evidence of rapidly progressing disease. And this year the FDA also allowed marketing authorization, and they were shorter, and for them the indication is to slow kidney function decline in adults at risk of rapidly progressing polycystic kidney disease. And when I look at these indications, I have 3 questions. First of all, there is no age range when defining adults. Whether CKD stage 4 is indeed allowed, and what the definition of rapidly progressing disease is. And to clarify these questions, to get answers to it, we sat together with a group of experts in Europe, and on behalf of the European Renal Association, we wrote recommendations for the use of tolvaptan in polycystic kidney disease. And these were published in 2016. And when writing this guideline, there were several underlying assumptions. We wanted to be conservative and not aggressive. We wanted that patients with rapidly progressive disease should be treated because they have the highest benefit to risk ratio of treatment. How then to define rapidly progressive disease? We defined it as a high likelihood of reaching end-stage kidney disease before the age of 58 and that is the average age at start of kidney replacement therapy in PKD patients. We also thought that we should not initiate treatment in patients with very late stage CKD because risk of treatment is largely unknown in these patients and benefit is moreover limited, as Jörg has also shown you. And 5, and that is an important point, and there we differ, I think, from the Americans, kidney function, in our opinion, is more important than kidney volume. Kidney volume is a surrogate for function, and function always trumps, overrules the surrogate. So when a patient has low kidney function for age, whatever the size of their kidneys are, this patient is a rapid progressor. And when a patient at a late age, at a high age, has still maintained kidney function, it is a slow progressor, whatever their kidney volume. And what we also thought that historical data are more important than risk prediction, but historical data, of course, should be reliable. Jörg showed you already our ERA EDTA position statement, and that looked very complicated, but it is a teaching instrument as well as a decision support tool. When we only use it to select patients for treatment, we can simplify it, and then you see this scheme. And it all starts that patients should have an age below 50, because that was the inclusion criterion of TEMPO, and GFR above 45, and eGFR index for age should be relatively low. When a patient does not meet this criteria, it is either likely slow disease or GFRs outside of the indication do not treat. When they meet this criteria, then we are going to look at the rate of GFR decline, and when such data are not available or reliable, only then we do rapid disease progression estimation with Mayo class. After the REPRISE study, I think this should be changed, because now, in my opinion, the age threshold is 55 years and not 50. GFR is not 45 anymore, but we have to look at the entry criteria of REPRISE, and that was approximately 30. And the remainder of the scheme is the same. And when we look at our population at our institution, and we have approximately 400 patients, you can see that approximately 1/4 of them would qualify as either proven rapid progressors or predicted rapid progressors, whereas 72% you need not to do disease progression estimation by, for instance, total kidney volume measurement. This is some real-world experience. 1/4 of the population in your outpatient clinic will thus qualify for treatment, in my opinion. And here we're looking at data that were obtained in Japan, real-world experience from September 2016, and at that moment approximately 2,500 subjects were treated with tolvaptan, and here you see the age distribution. And when you look at the age distribution, what I think is surprising, that approximately half of the patients has an age of 50, 55 or over, what in our opinion and also what the results of the REPRISE study were, that the drug has less efficacy in these patients. Another thing that is surprising is the dose of the drug that is used. In the TEMPO trial, the trial that showed efficacy, it was almost 100 milligrams per day, but in clinical practice in Japan, it was approximately 60 milligrams per day. And I think we should aim for the dose that has been shown in clinical trials to have efficacy. What about reasons to stop? In the clinical trials it was 23%, but in clinical practice, real-world experience, it was 11%. We often think of a clinical trial that people are highly motivated, and in clinical reality more people stop treatment, but the truth is that in clinical trials many people stop because the trial itself is a burden to them. They have to come quite often to a clinic and have to travel long distances to participate in this trial. And here in Japan, only 11% stopped instead of 23%. Of course, it may also have to do with the cultural background of Japanese people that perhaps are more adherent to medication. One of the big problems, of course, with tolvaptan is polyuria, and I think we can learn lessons there from the situation in diabetes, in nephrogenic diabetes insipidus. And we know as nephrologists that you should treat these patients by limiting their osmolar intake. And here I show you the results of this study that is going to be published in the American Journal of Kidney Disease next month, in which we looked at osmolar excretion on tolvaptan use versus their urine volume during 24 hours. And what you can see is that there is a very clear association between osmolar excretion, which is osmolar intake, and 24-hour urine volume. So when patients say that they do not tolerate the drug because of a high level of polyuria, we have to lower sodium intake, we have to lower potassium intake, and we have to lower protein intake, and that will get polyuria down in these patients to a perhaps tolerable level. That brings me to the lifestyle advice that we have to give, lifestyle modification. That is about water drinking. Drink more than having thirst to suppress vasopressin, because it possibly has an effect on eGFR decline. And we are told that we should aim for 24-hour urine osmolality below 280 milliosmol per liter, which is approximately 3 to 4 liters per day. I do not know whether that is feasible, because they have to do it themselves, but for instance, during nighttime, people do not drink and will not have a urine osmolality during nighttime below 280 osmol per liter. And I also do not know whether there is adequate vasopressin suppression, because during tolvaptan use, urine osmolality is 130 milliosmol per liter, and that's quite something else than the threshold of 280. And 130 patients should drink 6 to 8 liters. Another lifestyle advice is to reduce sodium intake to 3 to 5 grams per day. That's according to the World Health Organization. Just healthy food, it lowers blood pressure. It has possibly an effect on the rate of eGFR decline. There are now several observational studies showing this, and in those using tolvaptan, it will improve tolerability. And also to lower protein intake, no effect on eGFR decline. It may, in subjects with low kidney function, lower uremic complaints, but especially in those using tolvaptan, it will improve tolerability. And my last 3 slides are then on emerging treatments, and I listed here everything that is noted in literature, and that's quite a list. But I have to say this list is made especially when from animal experiments using zebrafishes. And I'm always surprised that whatever you give zebrafishes with polycystic kidney disease, nearly everything seems to work. And when you go to higher order animals like rat and mice, only very few of these drugs appear to work. And then in the last step, when we have to go from mice to men, then we also need a drug with an acceptable tolerability profile, because it's lifelong treatment for these patients. And then from this entire list, only very few drugs will remain. And I would like to make one exception there and mention Venglustat. Venglustat is a new drug. It's a so-called glucosyl ceramide synthase inhibitor, and it interferes with the glycosphingolipid pathway. And this pathway and these glycosphingolipids are involved with cellular membrane composition. And what has been observed in cells of mice with polycystic kidney disease, but also in human polycystic kidney disease cells, is that there is an accumulation of the more complicated glycosphingolipids. And that led to the hypothesis that when we would inhibit in this way with a glucosyl ceramide synthase inhibitor, that perhaps we could change the phenotype. And that is clearly shown here on the right top corner. These are mice with polycystic kidney disease, nephronephthysis, but also PKD1 mice, treated with vehicle or with this new drug. You can see that with Venglustat, the GSCS inhibitor, you get a better renal outcome. And it's done in a dose-dependent way that you have less of these more complicated glycosphingolipids, but there is also an improvement in size of the kidney, especially of the cystic volume, and there's an improvement in renal function. And one very intriguing point is that when you treat polycystic kidney disease mice with this agent, you see an improvement in urine concentration capacity. So these mice start to drink less and have less urine output. And that makes it perhaps a very logical and rational combination later on with tolvaptan with vasopressin V2 receptor antagonist. That brings me to my conclusions. There are very few proven strategies to slow progression of polycystic kidney disease. In fact, only vasopressin V2 receptor antagonists have been shown to be really have efficacy, and blood pressure it's likely. Tolvaptan is effective to prevent GFR decline, and in a real-world setting is reasonably well tolerated and safe. And with the current risk management plan, only one case of fatal liver toxicity has occurred. I don't go into detail of that, but I think that problem is not that large that some people think. And selecting patients for treatment is not that difficult. GFR, so kidney function indexed for age, works in most patients, and only in a minority of patients you need risk prediction, and we can then use either ultrasound or an MRI to measure total kidney volume. And when we then start tolvaptan, please use the appropriate doses and do not go to these low doses that has not shown efficacy in clinical trials. And when these patients have polyuria, don't feel sorry for them and go lower with your dosage of your drug. I think we have to limit osmolar intake, allow drug holidays when needed, and in the future we can possibly combine tolvaptan with other treatments that will improve tolerability. I thank you for your attention.